going to move into more of the concussion piece. I will revisit the imaging here shortly, but I thought it may be easier to understand the imaging if we talked a little bit more about the clinical picture that we see with people coming in with mild traumatic brain injury, i.e. concussions. So the problem is that historically, and not just up here, but just historically, concussions are really often mismanaged. And the reason that occurs is because they are underdiagnosed. And so one of the tasks that had been laid before us as an academy was to put together a toolbox of what is out there that has been a validated and reliable screening tool that we can use and we can put out to the general public as this is what you should be using in order to identify a mild traumatic brain injury, as well as to look at, okay, I've identified it, go me, what do I do? And so that's we put together the toolbox at the end of last year. And so what I'm giving you is what is in there. Basically, they pulled together a group of us and we made it and we put it together for online purposes, but I'm giving it to you as well. There's also a general lack of education as far as some of the new things that we're learning about mild traumatic brain injury. There's, again, this thought that, well, you should just get better. And if you're not getting better, well, then you just may have to live with it. Or, well, maybe it's just you have, anxiety, depression, something of that nature. And so really a lack of education out there as far as some of the new treatments that we have, new understanding as far as the mechanism of what is going on in the brain, and also an understanding of there are a lot more people that are developing post-concussion syndrome than anyone really wanted to admit. And there are a lot more long-term sequelae for concussion than anybody really wanted to admit. And so now that that problem is being recognized, we're also now starting to try to find treatments to address it. And so just making sure that that gets out there. And not just to the general community, but also to providers. And not just to, regular medical providers, but also to providers that you would think would know. But if, even specialty providers like neurology, PM&R, people that you would think would be on top of the latest research may not necessarily be on top of the latest research if this is not their field of interest. And so we're just trying to get this out there so people are more aware. And of course, the person living with the symptoms, well, you have a lot of increased psychosocial stressors going on when you're constantly fuzzy, irritable from known factors that occur with a mild traumatic brain injury, just from a chemical standpoint, difficulty getting back to work, perhaps plagued by constant headaches, and all of the other symptoms that can occur, well, this would increase some psychosocial stressors for you. And so when you're finally getting into a provider that can kind of understand what's going on, by that point, you're pretty much done. And you're like, okay, so what are you going to do? And so the goal is to try to get the treatment started sooner so that people don't have to get to that point. And that is where the screening tools come in. The OSU screening tool is one of the first ones we're going to discuss. And this is a tool that was developed at Ohio State University. It is called the OSU short form. Step 1 is the only thing you need to focus on. Step 1 has 5 questions that basically are all-inclusive for any type of possibility, etiology, or concern that somebody may have sustained a head injury in the past and has sustained a brain injury. When you look at it, ever hospitalized or treated in an emergency room due to injury to your head or neck? Think about any childhood injuries. In your lifetime, have you ever injured your head or neck in a car accident or other moving vehicle? Have you ever injured your head or neck in a fall from being hit by something? Or by playing sports or on the playground? How about from a fight, being hit or shaken violently? have you ever been shot, especially in the head? And then I also liked that we do have number 5 on there, because this is going to be much more of a concern in the community than some people realize. Up here, a lot of people realize that there are a lot of veterans up here. But as I go do other community lectures, they're like, oh, well, we'll never see that. Yes, you will. And these are blast injuries. And so we have a lot of vets coming back that have sustained multiple mild traumatic brain injuries from a blast. So those are your 5 screening questions. And this is something that anyone can do. And this is what you can use to identify a brain injury. Now, the SCAT-3 is a screening tool that's typically used on the field for sports. You can find it online. It is pretty much as cut and dry as what I just showed you. But that is pretty much that's been for about 10 years running the international guideline for detection of a mild traumatic brain injury on the field, and which is why it's on its 3rd life. It is the Sports Concussion Assessment Tool. A lot of people on the West Coast also use the Impact. Of course, there's the computerized version, and anyone within, especially, for instance, the Anchorage School District, any school athletes are supposed to get pre-screening with the electronic version prior to starting their sports season, and then if they sustain any concussion, they're supposed to get screening and return back to baseline before returning to the game. That's something that's becoming more and more popular and put out, especially over here. But there's also an impact screening tool that can be used on the field to determine if somebody's had a concussion on the field. The MACE is the Military Acute Concussion Evaluation. I put that on there for completeness, but it is something that we were using. I left Walter Reed in 2011, and it was consistently being used in the field at that point. Probably I'd say between 2003 up to 2009, it was hit or miss. And that's pretty far into the conflict. So you're going to have some people coming out who are veterans that may have not had the diagnosis ever made and may have been discharged from their respective military branch without the diagnosis because they didn't have it evaluated in theater. Now the Rivermead is the next thing we're going to talk about. And so when I said, okay, so you've diagnosed a concussion, what's next? This is the what's next. And so right now, and I'm going to give the caveat for most of what we're talking about in brain injury, we do not have a lot of firm and clear research on the things that we're doing because it is really just getting started. And anyone who's ever worked with research knows it takes a good 10 years to get any type of anything out the door. And so when you're considering that we just recently, within the past 10 to 15 years, started putting more emphasis on this with the NFL Players Association, you can see why we're behind the 8 ball. However, thanks to some of our partners over in Europe, we do have at least some things that we know that are accurate and good to use. One of them is the Rivermead. So there was a large Danish study that was completed, and this is the one that looked at scores on the Rivermead post-concussion screening questionnaire as far as how that related to long-term outcomes. And what they found was that people that screened positive on this concussion questionnaire were at least 3 times more likely to develop post-concussive syndrome. And when they continued following them out to 5 years, a large percentage of them were still not back at work. And so this is a good screening questionnaire to understand, okay, is this somebody that I think is just going to get better? Or is this someone that I'm seeing in my office, in my therapy place, in my home, whatever? Is this somebody that I'm concerned that may need to have supports sooner rather than later? Now, I will tell you that they are still recruiting the same people that did the original study, that they're actually doing this right now as far as recruitment for the study that's going to look at 2 arms, people who get into treatment sooner versus people who ended up just getting kind of shuffled into just regular treatment without any additional supports to see if there was a change in outcome. But on this side, over in the US, based on that research alone, we're looking at it and saying, if you have a positive Rivermead, you should get into treatment. And you can see, it gives a little brief blurb at the top. because this is something that is, you can just hand to the patient or hand to their family member. And it goes on a scale between 0, not experienced at all, and 4, a more severe problem. And then we go down to the list. Compared with before the accident, do you now suffer from? And it is a list of some of the most common physical and emotional symptoms that you can find after sustaining a concussion. Headaches is at the top of the list because that's one of our top symptom complaints that we see. But you can see dizziness, nausea or vomiting. And again, it's important, even though it's not recognized separately on this form, to determine whether there was actually vomiting based on what we had talked about before. Noise sensitivity, sleep disturbance, irritability, depressed or tearful, frustration, impatient, forgetfulness or memory issues, concentration issues, taking longer to think. There are a lot of processing speed issues. Blurred vision, light sensitivity, double vision, and restlessness. And then there's also a fill in the blank. So this is a symptom you have not listed, yet I'm having some significant issues with. And a positive Rivermead is 3 or more symptoms graded at a 3 or higher. So if you have somebody come in and they have a positive Rivermead, they are more likely to develop post-concussive syndrome. And especially if they have vomiting, even if they don't have a positive Rivermead, if they come in with vomiting, that alone should make you concerned that they're going to have difficulty with return to work. And so these are people that need to get involved with treatments sooner. These are not going to be your typical, well, go home, rest, brain rest, so forth and so on. You should just naturally heal. These are the ones that you should be looking at getting into therapy sooner and getting started with medication management sooner.
Amy,
Yes.
does this have a role in the acute inpatient same thing that it says more perforated than acute?
So the study was done on more acute. The study was done, most of the people that were in the study were post-MVA, and this was done in the ER or by their primary care, and then they were sent into the study. However, it can work in the acute inpatient setting because a lot of the times you'll have people coming in that they'll have other orthopedic injuries, and the mild traumatic brain injury kind of gets lost in the shuffle of a whole bunch of other things. So it can be very helpful for that. I will tell you, clinically, we've been using it also with chronic because we have a lot of patients that are having positive Rivermeads and they're 2-3 years out. But people are sending them in and saying, look, this is still there, we're starting treatment, and they're getting results. Yes?
I just had a question. I see a lot of ERs and urgent cares using the SCAT-3, almost trying to use it as a follow-up tool. So they're doing it when they present, even though it's totally obvious they have a TBI to a clinician. And then they're saying, follow up in a week and we'll repeat the SCAT-3 and make sure you're getting better. Does that make sense?
Yeah, well, I mean...
Or is that how it's supposed to be?
No. No, really not. That was made primarily for, now it can be used in ER, but the SCAT-3 was being used, it's primarily used for on the field, to pull people out of the game. For ERs, really, these two are all you need. And the repetitive testing for the SCAT-3 doesn't have sensitivity. If you're looking at repetitive testing, you're going to be looking at repetitive testing like doing something with impact or some type of neuropsychological assessment. The SCAT-3 does not have that sensitivity to do that. And so if you're just looking for, okay, we have somebody coming in, we need to identify it, boom, here are our 5 questions, we've identified it. Okay, what do we do with them? Do we just send them home with rest, or do we say, hey, you should follow up with your primary care, but then, however many days, base it off this. Yes.
So if you're having them fill this out post-injury, months down the line, do they fill this out as though they had just been injured, or what their symptoms are?
What their symptoms are now.
Okay, so you wouldn't have them do one and then compare it, just what they are now?
No, it's nice to know historically if they had vomiting, though.
Yeah.
That is one of the questions that I always check for in my history, because it gives you a lot of insight. But what you need to know is where they're at right now. Any questions on the Rivermead? Yes.
You have nausea and or vomiting
Correct.
together, so
And that's why I said the Rivermead didn't separate them out. It was a different study that looked at vomiting as far as a presenting symptom alone and the decrease in return to work. And so that's why I said, it may be important to even separate that out and make a notation, because even if their Rivermead isn't positive, if they have vomiting, that alone should be enough to make sure that they have close and adequate follow-up. And so then, what's been going on currently is it's just been a referral to match the symptoms. And especially if the concussion was not identified. So somebody's coming in and they're complaining a lot of the behavioral health symptoms, they're sent into the behavioral health network. If they're coming in and they're having a lot of the pain symptoms, either from migraine headaches or from pain from other orthopedic injuries that they sustained in whatever accident they were in, they can be sent to pain management. Or a lot of them, a lot of the times it's just kind of like this kind of limping follow-up with primary care or ER. Just this consistent not getting better. There's a reason that it's called the miserable minority. And that is because you have a minority of patients that just are not getting better, and there's just not adequate treatment and follow-up and referral into the system for them to improve. And so really, a complete history is needed. Vomiting is something very important, like we discussed. The Rivermead, it's good to know if they had a positive Rivermead. More than likely than not, they didn't have a Rivermead. Sometimes, more likely than not, they weren't even diagnosed with a concussion. You maybe just be sitting in the office or sitting in your workspace and have somebody complaining about these symptoms that sound suspiciously like a concussion after their car accident, but they were never seen for it, either because they never went in to get seen because they just figured they would get better and they were grateful that they weren't more further injured, or because they had a whole bunch of broken limbs and somehow that got missed during the entire hospital stay when people were worried about, making sure that their broken leg was healed and so forth and so on. So getting a good history, I like to try to figure out what the forces were that actually went through the head. So when I'm sitting and I'm talking about a car accident, I want to know about how fast was the other car going. Were you completely stopped? What area of the car did they hit? Were you wearing your seatbelt? Did the airbag deploy? If you were driving a smart car and they were driving a Ford 150, that's a big difference between two people, in a Nissan hitting each other. So getting kind of that information can be very, very helpful. And then a full exam. And basic exams, even basic neurologic exams, are going to be normal in concussion. That's part of the definition for it. And so you're digging a little bit deeper. And so for one thing, eye movements, we know, can be altered after concussion. And so that's something that I'm looking for. A musculoskeletal assessment. There is a lot of overlap between issues from the neck and the symptoms that it can create and those that come from a concussion. And so making sure that you're actually checking the neck is very important. And I'll tell you, one of the heads in our society, he laughs because he said, I cannot tell you how many patients come to my clinic and they said I was the first doctor to ever just kind of look and touch them doing my exam. And they're like, wow, nobody just ever checked that before. A gait evaluation, typically people have normal balance when they're walking unless they had a really significant concussion or you're seeing them shortly thereafter. However, it doesn't mean their balance is good. Because the minute I have them close their eyes and try to do something, they're wobbling all over the place. When we put them on a foam mat and they can't even stand on it with their eyes open, there are balance issues occurring. So good balance evaluation, especially if you're somebody that, and it's as simple as having them put their feet together, hands on their hips, close their eyes, and just make sure you stand close. And see what happens. Or have them lift one foot and try to do it, and watch what happens. They're not going to do too well on it. And if they're coming in with any other prior studies, just to look at it and see if there's anything, especially, if they had a CT scan, it's the typical, well, I went into the ER, I had a CT scan, they said I look good, they said to go home, they gave me a thing on brain rest, and I'm still not feeling well. So I went back with a headache, and they said, well, here's some pain medicine, you should follow up with your provider. So I did, and my provider's like, well, here's more pain medicine. And then and then it just keeps going and going, and then 3 years later, they're like, and I just still don't feel any better. And that's what leads, to the miserable minority. And they're like, and these are the continued symptoms that I have going on. And I was just told, and then I finally got to a neurologist, and they said, well, you may just have to live with it. And so they're like, and I really don't know what I'm doing here. And that's kind of a consistent pattern. Headache is the #1 complaint after non-traumatic brain injury, just #1. We don't have any great studies on post-traumatic headache subtypes. So to say that there's a specific treatment because you have a migraine from a head injury, that doesn't exist. So what we do is we treat headaches after injury the same way that we would treat a primary headache syndrome. So all of the evidence that we have and the treatment that we focus is based on the evidence, very good evidence, that is out there on how to treat a primary migraine, primary cluster headache, or a primary tension type headache. And that's how we base our treatment. Fatigue. And that is really how it feels. Because it's not tiredness. There's no pushing through it. And a lot of the times, this is one of those things that can lead to increased psychosocial stressors because the family's like, I don't get it. Why can't they just push through it? Well, you can't. Neurogenic fatigue, there's no pushing through it. When the bucket is empty, there is nothing to drink. And so you have to rest and recharge before you can do anything further. And this can be a huge issue alone. Anyone who knows somebody that has had MS, fatigue is a huge issue in MS. There are a lot of neurologic conditions where fatigue plays a central role. And if you are absolutely unable to get past a certain time in the day, you are absolutely unable to get past a certain time in the day. And so this definitely can affect return to school. It can affect return to work. And so it's one of the biggest things that we look at. And it is independent, although it can be influenced by sleep. So having something, they're like, well, I just don't understand why they can't do this and they're sleeping 16 hours at night. It has nothing to do with it. Nothing at all. They're sleeping that much because their body wants them to sleep that much. However, that being said, insomnia can definitely worsen it. And there are a lot of sleep issues after mild traumatic brain injury. And you can see the majority of people have difficulty not only falling asleep, but staying asleep. And that is hard to treat. Mood issues. Now, I put PTSD up here because this was something very commonly seen when I was in the military. And we ran the TBI clinic over at Walter Reed. And so PTSD was something that was so comorbid with mild traumatic brain injury that we just, after looking at it ad nauseum in the beginning of the conflict, stopped trying to separate it for treatment because it just didn't work. You didn't treat the PTSD and then somebody else would treat the TBI. We had a group together every week and we just worked together on treating both core symptoms. Because, one of the first things that we found was, well, maybe headache is the one that's TBI but not PTSD. Well, that's not true. There was really no way to separate out, well, which one is causing what. And so we went with the more functional approach of, well, does it really matter? We just need to treat both so that the entire person can get better. But that can go with any other mood symptom that comes up after mild traumatic brain injury. So while PTSD is very common, especially among military personnel, depression is very common. Anxiety disorders are very common. You can have somebody that had completely well-treated and controlled bipolar disorder before their mild traumatic brain injury that are suddenly not controlled on their medications afterward. And so it's not just new onset that you have to look at, it's people that had previous history of well-controlled that can now be not well-controlled. Or it can be somebody that was not well-controlled previously that is still not well-controlled. But you have to treat both. Yes?
Do you feel like the depression could be manifested by the fact that everything else is not being identified and treated?
There can absolutely be absolutely. There can absolutely be components of anxiety, frustration, irritability, and depression, not just from everything somebody's having to go through, but these can all be manifestations of somebody who's having acute migraines. And so you try to take a stepwise approach. And anybody that comes in and they're seeing me and they have not controlled migraines, that is the first thing I treat, because that can sometimes knock out all of their cognitive and mood symptoms and pain in one blow. Because migraines hit pretty much every system. Because like seizures, they hit multiple areas of the brain. And so you try to start with treating the issue that has the most coverage for what could, and it can also lead to decreased sleep if they're having issues with pain before bedtime. It can lead to nausea. It can lead to balance issues. Atypical migraines are super common after a head injury. I have tons of people that come in without the head pain, but these continued weird waves of dizziness rolling over them, and nausea and kind of just like weird visual symptoms that we find out are atypical migraines that completely resolve with treatment. So you start by treating whatever system holds the biggest breadth, and then you go from there. But absolutely, you can see mood components from the other things that are going on. Just like anxiety, I have a lot of people that come in, they're diagnosed with anxiety disorders, but what it actually is they have input overload. Their cognition is slowed, they get into busy environments, and it's kind of like taking somebody from, we'll say somebody from Barrow and dropping them in Macy's on Black Friday in New York City and saying, well, you're just very anxious. So, but that's the equivalent of it. And so it's, and they'll come in and they'll be like, well, they can find nothing for my anxiety. And I'm like, well, because I'm not thinking this is an anxiety response. And so it's trying to pick apart those pieces. Cognition. Cognition definitely can be affected with mild traumatic brain injury. And you can have persistent cognitive deficits from mild traumatic brain injury. And that is something that not everyone understands, because that just was not the thought process 15 years ago. Because it was basically, well, if you're still having cognitive symptoms, you must have something else going on that's continuing these symptoms, because you should be healed by now. And we know that's not the case. Definitely you can have cognitive issues after a mild traumatic brain injury. And it can be anything as slight as, well, I just feel kind of foggy and I'm off. I'm just not thinking as fast as I used to. I can't multitask like I used to. I just can't follow when there are 3 people trying to hold a complex conversation. Or sometimes if somebody's trying to show me something while talking about it, I can only focus on one or the other. You can't give me 2 different types of input for learning at the same time. It just escapes me. Memory issues. Well, I went to the grocery store, I couldn't remember what I went to the grocery store for. I assumed it was food. And I'm like, well, so, yeah. But, more often than not, being confused about recent events or not understanding, kind of context cues. So that it can be something very subtle. It can be something that's pretty disabling for day-to-day activities. And so definitely part of the spectrum. And then the cervical piece. The cervical piece is huge, and this is becoming more and more of a focus of research for brain injury medicine around the globe, because we're starting to see patterns that are just consistent and pretty, eye-opening. You can get pretty much almost the same syndrome from musculoskeletal input from the neck than you can from the original concussion, including cognitive symptoms. So if you have somebody and they've been treated from the top, basically I say from the top down, and everything's been stabilized and their impact is looking good and everything's looking great, but they're like still having these nagging symptoms occurring, and then all of a sudden you do something with their neck and they're like, wow, it's completely gone. Whatever that was, that fixed it. That's the cervical component that comes in. So I cannot overemphasize how important it is for somebody who's having these kind of continued drawn out symptoms to make sure that somebody has assessed their cervical spine. And I'm not talking they're going to have an MRI and be like, wow, you have a surgical spine. That is not the case. Typically the MRIs are very underwhelming. You're not seeing anything on any radiologic study. These are musculoskeletal issues. These are things like trigger points. But look at the referral patterns for the trigger points. So you have the X's where the trigger point is located, and the red haze is the referral pattern that you see from that particular trigger point. And those referral patterns look suspiciously like some of the headache syndromes we were talking about. I mean, it's pretty amazing what you can do just by adequately treating somebody's trigger points. Or nerve blocks. Somebody that has continued neuritic pain from the greater occipital nerves in the back of the head can just have these continuing kind of vague, headache-like, weird cognitive behind-the-eye syndromes that can be relieved with blocks. Or they can have just chronic kind of ligamentous loosening that's not enough that you see it on an MRI. And you really have to have somebody good looking at digital motion x-rays to understand what's going on. And typically, it's even really not needed, because somebody clinically who knows what to look for will see it. But you have these just kind of vague loosening of the ligaments that kind of leads to an overall instability with weak neck muscles, because, in this day and age, we are not that hardy. We spend a lot of our time at the computer. We have weak upper back muscles. We have, skinny little stocks for necks that are holding a 12-pound bowling ball of our head and constantly doing this, looking over a computer. We are not that hardy. And so we do not have strong necks like, somebody would have had 50 years ago. So you get an injury that's kind of a whiplash injury, you're going to notice continued effects from it. And so having these managed is super important, because you may find that this is what it took to get that last piece, that last symptom completely resolved. And then there's the vestibular system and the ocular system, which when I mentioned, one of the small things that we see on exam when somebody comes in is there can be issues with the, there can be basically difficulties with eye movements. This alone can lead into some headache syndromes, balance issues, and can really delay full healing. So getting somebody into a program where they get the rehabilitation for their vestibular system as well as vision therapy can be super, super important. And that's why I said at the beginning, knowing your referral network is more important than anything any one provider alone can do. Because if you can get somebody immediately that has a positive Rivermead into the therapies alone, a lot of the times they will progress very well. So getting that started is very important. Headache management is that easy. But no, it comes into the fact that there's no one medication that's going to manage a headache. There's no one medication that's going to manage mood. There's no one medication that's going to manage cognition. What you're looking at is you're looking at kind of a constellation of things to do in the environment, of things that somebody can be involved with that are going to help with their overall health and well-being. From a cognitive standpoint, more than any medication I can give is like, if you can tolerate going outside and doing some type of low-impact exercise, your cognition is going to be very much improved if you can maintain some type of physical activity without getting sick from it. Somebody had mentioned yoga. I love yoga, and I think it is absolutely spectacular for people after mild traumatic brain injury because it works on multiple different systems, especially if you consider you're including a breathing practice that can help with improving overall respiratory capacity. In some patients that can have problems with deoxygenation, dropped oxygen levels when they're exercising after a head injury. It helps improve overall just capabilities for physical activity as well as endurance. Can work on balance, and if you add the meditation piece in, it can also work on some of the cognitive and emotional symptoms they may be having. It is a great overall exercise for somebody to be doing, as long as they have a good teacher who is not trying to push them too far. And I always say, no hot yoga. You know, I'm like, don't. I had one of my patients, she's like, well, I went into ballet boot camp, and I said, honey, if it says boot camp, you don't do it, you know. So you don't go into, you know, like power yoga 301, but you're going into something that's a more restorative, you know, yoga system, and it works very well. But looking at everything throughout the day, if somebody's not sleeping well, they're not going to be doing well with their headaches. So you have to kind of look, if they're not eating well, you know, you have to look at the entire system before you just kind of try to start throwing medication management at it. And now we're going to talk about medicines on that note. But what I'm covering here is Class A evidence for prevention for different headache types. And so the first thing I'm going to talk about are migraine headaches, because migraines are miserable. They affect so many different systems. And as I said, after brain injury, atypical migraines are super common. I'll have people that had migraine headache disorders prior to their head injury that have a transition to a different type of migraine after their head injury, and it's no longer covering, their medications are no longer covering them. Or they were able to only use Imitrex, and now they're having them too frequently to do it. Things of that nature. Migraines are very common. Atypical migraines are very common. What are the Class A evidence medications that we have? There are 4 of them. So the top 2, topiramate, valproic sodium, or valproic acid. Those are anti-epileptic medications that have very good evidence for migraine prevention. The problem with, well, we'll start with number 1, topiramate, is it has cognitive side effects even in the best of us. And I have given it at very low doses, 25 milligrams, and had people go to the ER looking like they had a stroke because they were so aphasic. So it can be anything from very, very mild to very severe, and it is not dose dependent. But it works fantastically if you need it. Valproic sodium, or valproic acid, is another very good medication that helps prevent migraines, and I actually use this one quite a bit. I use it more than the topiramate, because if I have somebody coming into my office and they're having migraines, plus they're having issues with some irritability, this can help with the irritability. And so anything I can do to kill 2 birds with 1 stone, I really like. And so a lot of the times, if I'm going to go with this class of medication, it'll typically be with the valproic acid. Propranolol is a blood pressure medication, and I tend to not use this very much in my outpatient mild traumatic brain injury crew, simply because their blood pressure is so good that I cannot maximize it to effect without dropping their blood pressure. And so if somebody comes walking into my office and their blood pressure is 110 over 68, I'm like, well, that's just not going to work. Butterbur is what I use. a lot of the times is my first-line treatment. Butterbur is an herbal supplement that was studied extensively in Europe because they monitor their supplements like they monitor their pharmaceuticals. It's fantastic. It has Class A evidence for migraine prevention, and it is better than the pharmaceuticals we have at covering the symptoms outside of the headache, those prodromal symptoms that are so common in atypical migraines. So those people that have these weird waves of dizziness with vestibular issues that occur with their migraines, this covers that better than any of the other ones. The excessive yawning, the mood changes, the cognitive changes, there are a host, the visual changes, there are a host of different kind of off, weird, prodromal symptoms that can occur with migraine. Even my patients that have hemiplegic migraine, where when they hit, they just basically lose all sensation and strength on one side of the body and look like an acute stroke. This helps them more than the other pharmaceuticals. It just hits those better. It's 2 pills once a day. Works very well. Yes?
Is there a better
Oh, yes.
brand?
Yes.
Brand that you prefer?
Absolutely there is. Because what happened after this came out is everybody was like, oh, money. And so tons of people started putting Butterbur out there, and they did not standardize it well. And not standardized well Butterbur can lead to liver failure. The European Union's version of the FDA went a little crazy, and they were like banned Butterbur until they could figure out what was going on. And then they figured out it was because of these companies that were not standardizing it. So the standardization is super important. For that reason, there are only 2 brands in the U.S. that are recommended, Epidemiology and Swanson. I prefer Swanson for multiple reasons. Number one, because it is a 75 milligram pill, you only need 2 pills rather than 3. It tends to work better with less people complaining of either upset stomach or other, just kind of gastrointestinal complaints. And by some weird quirk of fate that rarely happens in the universe, it's cheaper. And so you can get a 2-month supply on Amazon for like $13. So it is not an expensive option, and it works very well. And I do not get any kickback from Amazon. Yes.
Can you repeat the dosage?
So it is 150 milligrams daily for Butterbur. So if you get the Swanson brand, those are 75 milligram pills. It's just 2 pills a day. The Epidemiology are 50 milligram pills, so that is 3 pills per day. Yes.
How about vitamin B2?
Going to be talking about that in a little bit. So that is the Class A evidence we have for migraine prevention. Yes.
So if people were to go online with this, though, you would recommend liver function tests periodically?
Annually. So there's other great stuff out there for migraines that is not listed because it's not Class A. Feverfew is Class B. That's another herbal supplement. And typically, if I start somebody on Butterbur and they're still having breakthrough, well, we'll try Feverfew.
In addition to?
In addition to, for prevention. Feverfew. And that is not brain specific. And then vitamin B2, which is riboflavin, also has, I believe it's Class C benefit. And magnesium supplementation, though that's my last resort because it will cause diarrhea. So, but those are some excellent that's excellent supplementation that you can use for migraine prevention. Yes?
And what kind of dosage do you use with the Feverfew?
So with the Feverfew, it's typically 480. And with the vitamin B2, it is 400 milligrams. Now, that being said, I want to remind everyone that herbal supplements can give allergic effects just like medications can. So I have a patient who had an allergic reaction to Butterbur. Herbal supplements can give the same type of allergic reactions that any medication can give. And it was confirmed. I sent her for allergy testing, And they time tested her with Butterbur, and she had the classic wheel and hive. She is allergic to Butterbur. You can have allergies to feverfew. So don't start anything more than one at a time, because then you're never going to know if one pops up. That being said, I use a lot of combination treatments for migraines because the goal, and here's the caveat, and we'll talk a little bit about breakthrough. You just absolutely should not be using breakthrough medications more than 8 days per month, 2 days per week, or you will get medication overuse headache. And that is Tylenol, ibuprofen, Imitrex, or any of the other breakthroughs. Those are short-acting medications. If you use them more than 8 days per month, you will get a medication overuse headache. And I know when people are doing it, because I will be like, okay, what do you use? Well, I use Excedrin. It works wonderfully. Where are all your bottles located? Well, I have one in my purse when I'm out. I have one in the car, one at the house, and my friend keeps one at her house. You can bet there's a component of medication overuse headache. And so it's very, very important to understand that what you're trying to do in controlling the migraines with prophylaxis is to make sure that people do not need to use medications more than 8 days per month. Amitriptyline and the tricyclic antidepressant class at low dose has Class A evidence for prevention of tension-type headaches. And yes, you can have more than one type of headache syndrome after a mild traumatic brain injury. You can have a tension-type headache and a migraine headache together. There's no rule that says you can only have one or the other. You can have more than one. And so a lot of the times, especially if it's a tension-type headache with a lot of muscular tension in the neck, it can irritate the greater occipital nerves and create what we call a cervicogenic migraine. So you can have both types. And so you can see people that are getting both types of treatment. Tylenol, aspirin, and ibuprofen have Class A evidence for getting rid of tension-type headaches, but again, they're all short-acting, so again, you can't use them any more than 8 days per month. And while the triptans don't have we don't have tons of literature behind them, but we just know that they have the best treatment recommendations for migraines. They work on the vascular component where the anti-inflammatories work on the inflammatory component for migraine abortion. Again, short-acting, no more than 8 days per month. Yes?
Dr. Murphy, when you say 8 days a month, do you mean combination, or do you mean like each, like don't take Advil for more than 8 days, but you can take Tylenol for 8 days, or?
Combination.
Combination.
So you can take it as many times in that day as would be recommended for that medication. So you could take Tylenol 3 times that day, you could take ibuprofen 3 times that day, you could take a combination of the two. But it's not like, well, I took Tylenol for 8 days, and then I had ibuprofen for the other 8 days, and then my triptans for the other 8 days, because that is short-acting medication on a day. And it doesn't matter how you mix and match. And you can imagine how difficult this gets if somebody has pain from somewhere else, and they're having to take a short-acting medication to relieve that musculoskeletal pain. Your brain doesn't care why you're taking it. You took it more than 8 days per month. And so that, for that reason, for people that have a lot of musculoskeletal pain that they're taking ibuprofen and stuff for, I'll tell them, well, why don't you go ahead and just try Aleve, and then that way you don't have to worry about counting your days because your knee's hurting. Because Aleve is a long-acting medication, it's not going to cause medication overuse headache. So fatigue and cognition. The first thing I do is I look at, okay, what medically could be the cause of this? A lot of the times, the medication list has something bad. And I'm like, well, there's the reason. If you're on a benzodiazepines and alcohol are the two things we know that will stop brain healing after a traumatic brain injury. You should just not be on them. Really, period. Unless it is absolutely needed for panic attack on an as-needed basis, you really shouldn't be dosed with benzos when you're trying to heal from a brain injury. And alcohol, I'll typically recommend either a year and a more significant head injury of full abstinence, or until they are completely healed and discharged from their concussion. Now, if it's somebody that has chronic alcoholism, of course, they cannot just stop, and that's when you're looking at sending them into a program where they can safely come off alcohol. Same with benzodiazepines. You cannot safely just stop benzodiazepines if you've been on them long term. They have to be slowly weaned, and they're not going to feel great slowly weaning off of a benzodiazepine they've been on for years. So that's something to keep in mind. That's the first thing I look for. The other piece I look at, yes?
Have you had an experience with TBI patients, particularly concussion patients, and trazodone used for sleep? And is this to be concerned about along with the benzodiazepines?
There are only two things that delay healing, and that is benzodiazepines and alcohol. Because trust me, I have a lot of patients that, the question came up and it was looked at with so many states legalizing marijuana. It does not delay plasticity. It has other things, but that's not one of them. So those are the only two things. And we'll talk about sleep meds here in a little bit. But if somebody is overly sedated on sleep meds, well, they'll be fatigued. Amitriptyline is a great medication for preventing tension-type headaches. However, it has a very long sedation profile, much more than others in its class. So if somebody had never been on medication before and they're on amitriptyline to help with their tension-type headaches and sleeping for 16 hours, well, it may just be the amitriptyline because they can get fatigued from that the next morning. And so then we try switching to other ones that have less of that fatigue profile, like nortriptyline. Medically, I have a patient who, if there's a patient that has a lot of stuff medically going wrong, you have to look at what other medical issues could be causing this chronic fatigue. Like my girl that had such a low blood count, such a low hemoglobin and hematocrit, that they rechecked her 3 times just because they couldn't believe it. And I'm like, well, that would do it. And so, you want to make sure if there are any suspicions outside of, the concussion, that those are taken care of first. So medication is one of the easiest ones you can look at and you can identify. But if you have somebody coming in like I did with a history of myelodysplastic order and all of a sudden they're fatigued, it's like, well, when's the last time you've had your blood checked? Using that type of, kind of, you're basically looking at knocking out everything that could possibly be coming in and adding to fatigue. When that is left, and it is neurogenic fatigue, and a lot of the times people with concussions are coming in perfectly healthy, so you're not worried about any type of, myelodysplastic disorder, and they're not using any alcohol, and they're not on benzodiazepines, and this is the history, and they're like, yeah, it's 3 o'clock, and I just can't do anything more, I'm hitting the wall. It's fatigue.